Yeah, absolutely. Welcome everybody to today's webinar, which is focused on what therapists should know about ending treatment with clients. We have an hour dedicated to this topic, so we'll spend about 45 minutes on content, and then we'll reserve the last 15 minutes or so for Q&A. So throughout the presentation, feel free to use that Q&A feature if you have specific questions. That way we can make sure we address those at the end. A little bit about Path Mental Health. If you're not currently a therapist in the network, we are a mental health care organization that is driven by technology. So we have thousands of therapists across the country. And our mission is really rooted in making mental health care work for everyone, meaning it certainly has to work for those that are in need of care, but it has to work for you and I, for therapists as well. And so how do we do that for our clients? We match them with therapists who accept their insurance, specialize in their care needs or diagnosis, who are accepting new clients. We even have options where you can filter finding a therapist through other criteria that can be really important for clients. And this is really critical, right, to establishing that therapist-client fit that's so important. For those providing care for the therapists in our network, we're essentially a practice in a box. So we provide all of the admin side of things. So billing, credentialing, verifying client benefits, scheduling, giving an EHR to document in, all of those things that are necessary to sustain a practice, but frankly are not the funnest part of operating as a private practice therapist. So that way you have the time and energy to focus on what you do best, which is providing care to your clients. And then lastly, a little bit about me as a facilitator for today. My name is Anne Jackson. I'm a licensed therapist in Colorado. And at Path, I'm a clinical quality coach. So I've been practicing for the past 15 years, primarily in community mental health and inpatient settings, as well as telehealth work. But my job as a clinical quality coach at Path is really to support therapists in practicing in a way that is meaningful and sustainable and effective. I always say I want the therapists in our network to have autonomy, but not isolation. That's usually what concerns people about going into private practice, is the potential isolation. So that is part of my role in supporting our providers. We're also joined by my colleague, Jen. So she'll be helping everything run smoothly today, as well as helping moderate the Q&A at the end. So without further ado, let's get started. So our goal for today is to really consider how we can take the information we're going to discuss and put it into practice. And very simply, how we're going to do that, we're going to start by talking about the different circumstances in which we consider ending treatment with clients. Many, I'm sure, we have experienced ourselves in our practice. And then we're going to talk about some strategies for doing so. And then lastly, as I mentioned, we'll make sure we have some time at the end for Q&A. So whether we call it discharge or termination or ending treatment, I think the question is still the same. Like, when is it clinically indicated? The most ideal reason, right, would be successful completion of goals, or the presenting problem has been resolved. That's what we're aiming for. And many of us are trained when to recognize this has happened, but not necessarily trained in how to carry out the process in a really effective way. We kind of wait till they show signs of readiness, and then we just broach the topic of discharge. So we are going to talk today about a path, if you will, on how you can really plan for effective discharge for clients who successfully complete goals. That being said, what about the other reasons why treatment might need to end that is not as clear, or maybe not as feel good for us or the clients? Things like when a client's not meeting medical necessity for ongoing care. This especially comes up in commercial payer world, where we're actually required as part of payer contracts to demonstrate medical necessity for the service in our documentation in order to be reimbursed and in order for additional services to be authorized. So it really can be the difference in the payer saying, we're not going to pay for any more sessions. So if medical necessity is not really there, it can result in treatment needing to end. Poor therapeutic fit. So, what about when it's just not an effective match? And that can be for any number of reasons, of which we'll discuss. But this brings up a lot of questions around, like, fear of client abandonment or ethical obligations and so forth. But that certainly can be a reason why discharge might be clinically indicated. And then disengagement. Sometimes our clients just stop. They stop showing, they stop responding to outreach, or they have very inconsistent engagement. And so how do you determine kind of how long you hold on? When do you discharge? How long do you outreach as well? So in recognition of all these different experiences that we have as therapists and as clients, we're going to take a closer look at each one of these and then just talk about some different considerations to keep in mind. So let's start with the ideal. How are we setting ourselves up and our clients up for success from the beginning to work towards an effective discharge experience? This resource is from Therapist Aid. If you use Therapist Aid a lot, you might have seen it, but I come back to this again and again because I think it's very simple and very effective in use. The first thing we have to do is prepare from the start. So we want to begin laying the groundwork for successful termination from the very first session by describing therapy as a time-limited process. We may enter the therapeutic relationship knowing that, but oftentimes our clients don't. And so we want to have really clear conversations from the beginning that therapy will not go on forever. And that usually the goal for therapy is not to eradicate all symptoms, right? To be void of any anxiety, any stress, any depression, because I think that's kind of inherent to being human. I mean, majority of us in this space today probably can relate to experience some of those things, maybe even daily. So I think instead, if our goal is to really help the client develop the skills and the tools or make the changes that allow them to live a meaningful, healthy, functional life, even if they still experience some ebbs and flows of those symptoms, it really sets termination up as a positive goal. Like, this is what we want, is to give you these skills and these tools so that you are able to live the life you want and not necessarily be in therapy forever. So once we've kind of laid that foundation, it's really also important that we're setting goals in the treatment plan that denote a finish line. It helps give each session direction, right? If we know what we're working on. And without it, therapy can really easily become pretty chaotic and kind of aimless. And I know I can think of so many experiences where I have a hard time even wrapping my brain around what we're working on because there's so many complex presenting problems. And what I found in those experiences is that I often feel really ineffective and the clients feel like therapy is ineffective because we're just kind of spinning together. So having really clear goals that mark the finish line, what are we working on? What are we working towards? Can really help mitigate some of that experience. And then as a quick side tip related to that we talk about a lot in our case consult sessions at PATH, is how you open sessions can really help support or complicate this. So when you open a session with a very broad opener, like, how have you been? Or, so what's been new with you in the last 2 weeks? You tend to elicit very broad responses in return that may or may not even be related to what you're working on as part of the treatment plan. And as I mentioned, that makes it tough to kind of stay in alignment with the presenting problem and the treatment plan goal. And things can get really kind of chaotic. So typically it can be more effective if you open your sessions with a more targeted opener. So instead of just saying, so what's new with you lately? Saying something like, how has your anxiety been when you've been out in public lately? I know that's something we've been working on. So you're still inviting them, to share and disclose about how things have been since you saw them last, but you're really targeting how that aligns with a treatment goal. So once we have our clear goals in place, we're providing treatment, we're helping them make clinical progress. And throughout that period, we're always gauging readiness, right? Have they maintained a reduction in symptoms? Have they made notable progress? We're gauging this based off their response, but also our own observation, our own assessment, use of standardized measures, which we'll talk about towards the end of today. And it's asking the client questions sometimes of what we've done so far, what's been most valuable to you, or even if they're small, are there any positive shifts that you've noticed, and helping them really connect the dot of how far they've come and maybe how far they still want to go. But once we do determine that we feel like they've made progress or we're working towards being ready for discharge, we want to establish a mental health maintenance plan. So I think many of the issues that bring clients to therapy have a high risk of relapse or just require ongoing maintenance. And so a mental health wellness plan, maintenance plan, whatever you want to call it, aftercare plan, is really just a way to support our clients in recognizing that even though they've made great progress, to equip them with a plan, moving forward on, recognizing symptoms and triggers and warning signs and what coping skills and things they found effective. It kind of mirrors a safety plan, but I think so often we use safety plans in the context of risk or the presence of suicidal ideation. I think having a wellness plan that kind of zooms out and looks at the whole experience of just maintaining your mental health can be really helpful. I feel like we see this done really well in medical care. So some of you, if you reflect on experiences you've had maybe with a surgery or a procedure, usually when you discharge, they give you an aftercare plan that tells you may experience like these certain symptoms. And if you do, here's how you can respond to it, right? To lessen the discomfort or the pain. And it usually involves saying something like, if things get worse, here's who you can call. Here's when you would need to come back to the emergency room if you see these things happen. I think a mental health maintenance plan can really replicate that process by just giving them something tangible to say, I made such great progress. I feel ready to discharge and I'm human and I have a plan in place if things start to kind of bubble back up. And once we have that in place, I think we can really confidently move to discharge. So again, this is pretty simplistic, but I think when we're thinking about those clients who do meet their goals, they've made progress, it's a way to just make sure that we're approaching discharge from a really effective strategy as opposed to kind of haphazardly, which sometimes can happen without it. So just some things to think about. All right, so now let's dive into these other reasons that, as I mentioned, sometimes are not as ideal or feel good reasons we might need to end care with our clients and some considerations around doing so. The first is having to determine if clients actually meet medical necessity to continue outpatient behavioral telehealth treatment, if that's the service you're providing. Which in simpler terms, I think about it as really just answering this question, like, what is the function of treatment for this client? Treatment can serve a lot of functions for clients. What is this function for this client? So specifically, we're asking ourselves, is there a diagnosis, symptoms, functional impairments that justify needing therapy? And does the goal for treatment and the interventions that I'm using align with those symptoms, those impairments, and the diagnosis? So these two items combined are really what reflect medical necessity for the service. And this is required for commercial payers. So if you are seeing a client who has commercial insurance, documentation that reflects medical necessity is a requirement across the board. And sometimes this is really obvious. It's not hard to demonstrate medical necessity. There's clear symptoms, there's clear functional impairments. The treatment plan makes sense, to be responsive to those things. So sometimes it's really clear. But what happens when the rationale for treatment is primarily relational or supportive? Meaning sometimes we find ourselves in situations where the client is not meeting really any criteria for a DSM diagnosis. They don't have any evidence of functional impairments. Their symptoms are very, very mild. However, they're human and they value the connection, the listening, the positive regard that you offer. And when we find ourselves in these situations, therapists will often ask, like, well, if they're getting something out of it, like, who am I to tell them to stop coming? Who am I to tell them that, we can't continue? And the answer is, if they have commercial insurance, if medical necessity is not present, treatment's likely not going to be a covered service. This can look different if you're caring for self-pay clients, which we won't talk about much in this webinar, but really through the lens of commercial insurance, it's kind of it is a non-negotiable rather. And this may involve then some level setting, like having a clear conversation about what therapy is, what it isn't. If a client is saying things like, you're just such a safe person that listens to me, it's comforting seeing you each week. We want to validate that. And that's really evident of a strong therapeutic alliance, which is fantastic. But we might need to work with them on really defining but what necessitates having a licensed therapist provide that support. Sometimes you might have heard this reference before around if it's something that a neighbor or a friend could do, typically it's not necessarily going to meet medical necessity. For example, sometimes I'll review notes and the note session summary will say something like, talked with client about recent divorce, offered support and listening. There may have been clinical skills that was used in that, but just based off those sentences, I mean, a neighbor could talk to someone about the recent divorce and a neighbor could offer support and listening. We need to be able to piece out a clinical intervention that was used, as well as more clinical content on the specific symptoms, functional impairments that justify needing a therapist to do it. And then one final comment on this, I think sometimes it can feel confusing when we're saying, well, isn't the therapeutic alliance the most important thing? It is. These are really paired concepts. You can't really have one without the other. We want clients to always feel seen and heard and connected. It is critical to care. However, we do need that to be paired with medical necessity in a commercial payer world to make sure that services can get authorized and care doesn't get interrupted. Another reason we look at ending treatment before a client has reached their goals is due to client-therapist fit, because it matters a lot. I'm sure many of us in this virtual space can reflect on experiences we've had where the fit maybe just wasn't there. And it shows up for ourselves and our clients in a few different ways. One of the ways it can sometimes present itself is unchanging or worsening symptoms despite efforts to adjust the treatment plan or adjust our interventions to try to meet their needs. So we've been working together for a while. I've used all my skills, my approaches, interventions. Maybe I've even tried on skills or interventions that I didn't use previously to try to help them progress. And it's just not happening. This doesn't necessarily mean that you are ineffective as a therapist or bad at what you do. It can really just mean that the fit between the client's needs and my skills are not the best match. I often describe the work we do in outpatient behavioral health. We're somewhat like the PCPs of behavioral health, meaning we often, I think, experience pressure to be able to treat anything. Anything that gets referred to us, somehow we're expected to inherently know best practices for and interventions for, but not every client needs CBT or DBT, and not every therapist is trained in EMDR or IFS. And so it's okay if you do reach a point to say, this is just not the best fit therapeutically, and it might be appropriate to end treatment with them and get them connected to a provider who better serves their needs. Another way this shows up is when clients, have treatment needs that require a higher level of care or more wraparound support. So I mentioned my background in community mental health, and others on this call, this may resonate with you. I mean, my clients on my caseload then had me, but they also had a case manager and a peer support specialist and a group therapist. So even though that was still outpatient care, they had a whole lot more intensive level of support embedded in that outpatient treatment. And so sometimes, a client just engaging in weekly or even twice a week telehealth therapy may not be adequate to meet their needs. And sometimes we don't discover that until we've already begun care and it becomes apparent that either their expectations or their level of need is not in alignment with that. So it is appropriate to end treatment and to transfer them to more wraparound support if that's what is clinically indicated. Another one that comes up often is just telehealth itself not being the most effective treatment modality for a client. This comes up in so many ways. I think a few of the most common that we talk about in some of our consults with providers at PATH, technology. For some, technology feels very comfortable and familiar. For others who struggle with the use of technology or don't have access to reliable, high-speed internet or devices, it creates this additional layer of anxiety and stress that sometimes can actually be distracting or impede the therapeutic process. Clients with more significant challenges in communication or verbal engagement. It can also be really hard for therapists to interpret, nonverbal cues, gestures, how to interpret pauses, especially over the phone. And so there just clinically may be reasons why telehealth is just not optimal. And then some clients may not always be the best at protecting their confidentiality. Some of you may have experienced this as well. I've noticed it more so with older adolescent clients, and then having parents or family members kind of in and out of the room. You want to create a space where they can, be fully present and fully honest, but that can impact the relationship and the efficacy of what we're trying to do if you're not really clear how comfortable they are in, disclosing things and truly keeping it confidential, or if others are within earshot and stuff. So it's not for everybody. And if you are a telehealth provider, this is something that comes up and may need to be discussed. And lastly, interpersonal differences between the clinician and the client that cannot be overcome. So we talked a little bit about it earlier, just the importance of the therapeutic alliance, but research has shown that the therapeutic alliance is 5 to 7 times more effective than the therapeutic technique in determining counseling success. So this fit in the interpersonal relationship is extremely important. We make our best effort when there are interpersonal differences. Sometimes that can be an intervention within itself to work through that dynamic. However, if you find yourself and the client finds himself at an impasse where there are just inherently things that are not in alignment, that are going to impede clinical work, we're not able to establish a strong therapeutic alliance, you should absolutely consider ending treatment so that they can access a therapist who would be a better fit. I've heard this reference as like no fit, no fault approach, where it doesn't mean that the client is broken and unfixable. It doesn't mean that you are ineffective. It means that it's no one's fault. This is just not a good fit. But I think sometimes we can experience this parallel sense of like, we want to be effective, so we're just going to keep trying and keep going. And I think it's important to recognize at a certain point, they're really, these may not be able to be resolved, and we should really refer out. And lastly, disengagement. So as I mentioned at the start, sometimes clients just stop coming, they stop responding to outreach. So what do? In private practice, it's really up to you. So when you work under agencies, usually they have kind of a procedure or a policy. Typically in private practice, it's up to your discretion. A common practice that I know many therapists in the Path Network use, and something I use myself, is what I call the 3 and 3, which is making 3 different outreach attempts over the course of 3 weeks. So this may involve call, email, text, and each time you're asking for a call back or a response to let you know if they wish to continue care. If they do not respond, then on that 3rd outreach, I let them know that, because I have not heard back from them, I'm going to close them out to care with me. If they wish to resume therapy at any time with me or my practice, how they can reach back out and get that set up. So that's a good kind of middle ground that I think a lot of providers feel comfortable with, to spread out over 3 weeks before you move to close. In addition to how they can resume therapy, I personally also really recommend referencing in that final email or that final call just additional supports available. So I always mention 988, and that they can text or call 24/7, crisis centers, if they have those in their local area. It's just a nice way of being able to remind them that there are immediate accessible supports, even if my work with them is not continuing. And then just a reminder that documenting the actions that I just described is really important, because that's what creates this paper trail of your efforts in engaging, seeking to engage the client and giving them supports available. Sometimes clients have a very different interpretation of the process or different expectations. And so just having that in the client's chart, I think, can be very protective for us as providers, but it's also just really helpful to have that history as a reference. If they do come back for treatment later, you have this nice, like I said, paper trail that shows when you outreached, what you offered to them, so that it's in the chart. All right, so talking through the different contexts in which we may be looking at ending treatment, I do want to create a little space just to name why this can feel hard, why we can be hesitant sometimes to end care for really any reason other than them successfully meeting their goals. I think it's important to name and just norm that there's a lot of vulnerability and expectation that happens in the therapy process for both us as providers and, of course, our clients. I mentioned that kind of like parallel experience of perceived failure. So clients feeling like, I'm not fixable, I'm broken, no one can help me, I'm clearly, too complicated for this therapist. And also us as providers feeling that sense or worrying like, gosh, am I jumping ship? Should I be working harder at this? Should I go learn more so that I can effectively meet their needs? So we're kind of simultaneously experiencing this fear of feeling like a failure. And that can be really complicated and it can bring up really strong emotion. So I want to just name that I think that comes up often when we are thinking about discharge or ending treatment. And then I think this is often compounded by the fact that, the therapeutic relationship may be one of the only times, if the only time in our clients' lives when they have experienced safety and trust and compassion and care. So it makes sense that clients would be reluctant to want to end that relationship. It also makes sense that as therapists, we would be reluctant or hesitant to want to end that for them. So I've heard it a lot where therapists say, like, I'm all this person has. And I would encourage you, if you find yourself in that situation, the treatment goal could actually shift prior to discharge of like, how can I support them in creating a support network outside of me, right? Maybe there are social skills, maybe there's, certain things, certain actions or steps that they can take to really build more of a community so that when it does come time to discharge, we're not necessarily eliminating their only support. And we know that some clients manifest this reluctance by continually raising new issues or concerns anytime the possibility of termination is mentioned, or they just constantly present with new issues because we're human, right? And so one way to think about this is, imagine if you had a standing appointment with your PCP every Thursday at noon. Every Thursday, you're going to check in with your PCP. I imagine that sometimes you might actually have a presenting problem, right? Something targeted you want to talk about. But I also imagine even if you didn't, you could probably think of things to talk about, to share, and it would probably feel pretty comforting knowing that, oh, well, I'll see my PCP on Thursday. I'll ask about it then. That is a little bit of a different experience than your primary care doctor, which is what they do, saying, you may experience some symptoms. I want you to monitor it. If at any point you have, worsening of symptoms, if, you have a new presenting problem that necessitates a doctor, I want you to come back. But we don't just kind of maintain these standing appointments just in case something comes up. We see our PCP with a targeted treatment focus. And so it's important that we're kind of helping frame therapy the same way for our clients. But even knowing all of these things are true, I do think many of us struggle with this fear that, like, if we initiate ending care, what if they do feel abandoned? What if they decompensate? What if they get worse? And so I want to norm that. That shows that you're a very compassionate, present therapist, really thinking through, their clinical needs. But I also want to encourage you, like, this is where, seeking consultation to just affirm your assessment of things can mitigate some of that anxiety. Certainly putting referrals in place. Now, whether or not they access those referrals, we don't have control over, but that can really mitigate some of that anxiety to say, I did do my due diligence they've got a safety plan. I gave them crisis resources. I referred them for this other support, and I really hope they access it. And then documenting all of that. I think many of us, in full transparency, probably dread documentation a little bit. That's not why we got into this field, was to write notes. But wow, it can be so protective for both us and the clients, just making sure we're capturing these things in a client record. So as we close out, I just want to reinforce some of the approaches that we've discussed that I think can be really effective as tools to kind of navigate, some of these situations we might find ourselves in. And the first is kind of reinforcing this idea of co-authoring a discharge plan. So we talk a lot about co-authoring a treatment plan, right? That's something we do together. It's collaborative, but it's also important to co-author a discharge plan, meaning we start talking about discharge at the onset of care, which I know can feel strange. But what that does is it supports us in constantly revisiting this question, which I use with clients all the time, of like, how will you know when our time working together has come to an end? You will learn so much from a client's response to that question. You will learn so much about how they perceive treatment, how they perceive their treatment goals, how they perceive the work that you're doing during session. But this does help kind of set and reinforce that expectation that therapy will end, but we want to empower clients to help determine when it will end. Trusting clients, actively listening to their sense of how they are or not benefiting from counseling helps them prepare well in advance for discharge. It really mitigates this potential experience that, we've been thinking about discharge for quite some time, and now we're broaching it to them, but it feels new to them. I almost liken it to if you've ever been in a relationship where someone has been planning their breakup with you for quite some time. And so you feel blindsided, but they've been plotting for weeks or prepping how to do it. It can be a really difficult experience. So really including them in that discharge planning process throughout treatment, even when we're still in the thick of working on things, can be really helpful in helping it feel co-owned. There also may be instances where the client disagrees with your assessment and they want to keep seeing you despite, you evaluating like there's really not medical necessity, or, they really need someone who does trauma work and I don't specialize in trauma. So I encourage you to really own your expert lens in these situations, because I think it can be tempting sometimes for us to kind of cave into that because we want to meet clients where they're at, right? We were trained that and we seek to do that all the time. But again, I would just encourage you to not be afraid to really lean into your expert lens, sticking to the assessment that you've made, and knowing that even if it doesn't feel super good, there is a clinical rationale behind it. To me, this is similar to how we diagnose. So some of you may relate to this where you have a client and you give a diagnosis based off your assessment and their symptoms. And they say, I don't like that diagnosis. Can we change it? Or I've had clients say, I don't want a diagnosis at all. I don't want a diagnosis in the record. Can you, remove that? And in those cases, we don't typically say like, okay, well, what diagnosis would you like? Or let's find one that feels comfortable, right? Or let's remove the diagnosis. We give space to really talk about and acknowledge their concerns, fears around stigma, all of the things that are eliciting that desire. But our clinical assessment doesn't necessarily change, right? We really lean into that and we stick to that. I think decisions around ending treatment, it's important to practice that as well. We also want to emphasize what won't change. So similar to the commentary I gave about like reminding clients of 988 or crisis centers or other support lines, we want to do this early and often. I think termination can feel like such a big change, and part of effective transition management is illuminating what's not changing. We do this with young kids all the time. What is consistent, what is predictable in their lives. But adults benefit from this too. So this could be related to, other mental health supports that are, still going to be there, that are still accessible, but also could be, community, family, friends, but really reinforcing that for them more than once can be helpful to navigate those discussions. And lastly, the use of measurement-based care to inform clinical care decisions. So we certainly won't deep dive into this, but I do think as we close out, it's helpful just to highlight how you can incorporate measurement-based care specifically in thinking about prepping or navigating discussions around discharge. I personally think use of standardized measures is one of the most underutilized clinical tools in practice. Many of us have worked in places where you had to administer like the PHQ-9 or the GAD-7 as part of practice. But I don't know about you, I was never really trained on what to do with the data. Like, how do I make it clinically meaningful? And what happened is it wasn't clinically meaningful because we didn't ever talk about it with the client. I didn't really know what to do with it. And they stopped completing it because why would you keep completing something if you're not really sure the clinical purpose? So the way I explain it to clients now is I liken it just to like when your PCP takes your blood pressure every visit. That blood pressure score doesn't replace their whole clinical assessment. It's just one more piece of information. It's a tool in their toolbox to help inform or shape interventions or what the client or patient needs. But it's a tool that really speaks for itself. And I think it can be really, really powerful in a few different ways. Specific to discharge discussions, I mean, it really can function as a great way to breed reflection, and not just reflection on what you see as a therapist, reflection on their self-reported items. Because remember, like, they're completing the measure themselves. So being able to look at trends over time, score change over time, what do they notice? How does that match up to the progress they see? I've had clients before that will say, like, I don't feel any better. I feel just as depressed as when I started. But then when we can look at their PHQ-9 scores over time, you can see that there has been a shift, maybe not huge, but there has been a shift from their self-report and how they responded to the item. So it's a really great tool for reflection. Self-monitoring, so this skill of observing, rating, tracking, noticing the variability of symptoms day to day or week to week, is a great clinical skill for them to take and practice even outside, or once treatment has concluded. So, this ability to recognize, if I were to rate and monitor my feelings of worthlessness on a scale of 1 to 10, what does a 10 feel like? What tends to happen in my body? What tends to happen emotionally in my environment when I feel like a 10 out of 10? And what ways have I learned to respond to a 10 out of 10? Because when you reach a 10 out of 10, it's less about self-care and coping. It's more about self-preservation. Like, what are the core things I have to do just to be able to get through? What does a 5 look like? What does a 5 out of 10 feel like? What are the skills I use when I'm a 5? So these are things that kind of transcend even being actively engaged in therapy, and that people can use. Self-monitoring often starts with standardized measures. They get used to seeing a score and how each item, rates and how they all, combine together. And so can be really helpful in using that throughout treatment, but especially when thinking about that aftercare maintenance plan. And lastly, this opportunity to normalize that the goal is not to be a 0 score on measures. So I think as humans, sometimes we have a tendency when we're filling out a document that has numbers involved, it feels like a test, and it feels like the goal, or when I'm done with therapy, I'll be a 0. And just like I mentioned before, this serves as a really great opportunity to have a conversation with clients around the ebbs and flows of symptoms and, the severity of symptoms. When you think again about medical necessity, mild or no symptoms tends to not meet medical necessity for outpatient care, because we know that, any of us in this virtual space could fill out the GAD-7 right now, and we might have some numbers on it, right? Because we're human. So having conversations about the relationship between symptom severity and readiness for discharge, measurement-based care is a great way to do that. All right, that was fast and furious, but I wanted to make sure we reserve time at the end. So I'm actually going to stop screen sharing. I do have my email there listed at the bottom, and my door is always open if you have other questions that we don't get to answer, or you want to connect with me directly. I think Jen can plug it into the chat as well if you don't have a chance to grab it. But I'm going to stop screen sharing, and then I'll pass the mic over to Jen, and maybe we can dive into some Q&A.
Yes, thank you so much, Anne, for that wonderful presentation. And thanks to everyone who's been dropping questions in the chat and QA. So I'll go ahead and tee up some questions for Anne. The first one, Anne, we have someone who is asking, I just got the PATH message that my client's episode of care is almost complete and 3 sessions remain. How would you prepare the client for discharge during the last 3 sessions?
Yeah, great question. Well, and to be clear, I'm assuming that means that you also feel like treatment is appropriate to end, right? Because sometimes with commercial payers, they only auth a certain number of sessions, and then based on the medical necessity in your notes, they'll give more. So Kaiser is a great example of this. They tend to do an initial bucket of like 16 sessions, and then they want to see basically proof that the client needs more care, and they'll authorize another 10. And then they'll review again and authorize another 10 and so on. So if you think they need more care, it may just be a matter of making sure the documentation meets that. If you feel like, yeah, I'm in agreement, like I think we're ready to wind down, I would actually revisit some of the content that we discussed, like, what's changing and what's not, and really talking about that. Having reflective conversations about, what they've learned or what's been valuable during their time in therapy, and or creating that mental health wellness plan or maintenance plan, and spending a few sessions focused on that. So again, I think using it to really norm for them, like part of being human is that you may feel great today and then life happens. And so you do have the skills and the insight and the ability to navigate anything that's going to come at you. Let's put this down in writing or in their phone, however they want to use it so that they can revisit it. So that could be a helpful way to kind of wind things down.
Awesome. Thanks, Anne. Next question. Could you speak a little bit more to the process for how many times you should attempt outreach after a no-show before rematching or discharging?
Yeah, great question. And I do want to reiterate, like, I don't think there's actually an industry standard for the best practice of like the best way to do this. It really is different clinician level of comfort. And the other factor that comes into play is clinician capacity and revenue. So for some people in their practice, the longer you hold on to that person as kind of an active member of your caseload, they're occupying potentially a spot that a new client could get scheduled. And that can impact your livelihood, your revenue, right? Your work. And so finding that sweet spot of creating enough space for the client to be able to re-engage, and also a little bit of your own self-preservation of your operating a practice, can be difficult. But I think that 30-day tends to be the most commonly one that I see used. And me personally, I think that's clinically appropriate. I think 3 weeks or 30 days is a generous amount of time to try to have someone respond to your outreach. I think trying a few different modalities, like I texted them, I called them, I left a voicemail, is also, I think, a very well-rounded approach. And if someone hasn't, followed up with you after that, I personally feel comfortable saying, this person I don't believe is interested in continuing treatment. I've given multiple opportunities over the course of 30 days. And I'm giving them resources. If they want to come back, they have the resources to do so. Something I will say some therapists do kind of exceptions to this is certain clients that tend to be like higher risk, or have certain clinical factors that they just don't feel like 30 days is sufficient, or they just want to give it more time. That's totally okay. I had a therapist a while ago in case consult that had a client who had disengaged, but had a history of like really negative experiences with behavioral health, and had been very vocal that like this provider was the only and first time they had ever felt seen and heard, and they had made a lot of progress, but then like a life event happened and they kind of fell off. And this provider's like, I don't want to give up their spot, because I think if they are going to come back to treatment, like I feel like, therapeutically, this would be the best place for them to come. So it's like, great, it's your practice. So I think she was going to hold on for like 90 days or something. And so it really is your discretion, but, other providers might have other ideas too. But I think the 3 outreaches in 3 weeks for me works.
Great, thanks, Anne. Another question, this one PATH specific. Does PATH have a maintenance plan template?
Ooh, great question. We do not, but that's something that I can create and I can put in the Therapist Help Center. You may have noticed some of the videos with like sample notes and, how to write a treatment plan and things in the Help Center recently. So we're working on building out my vision for the Therapist Help Center is that there's this clinical corner that is just a repository of like, if you want to see a sample of something, if you need a template, right where to go. And so I will take that as a suggestion and work on putting that together. I think that would be great.
Great, thanks, Anne. Okay, another question. Can you speak to PATH's higher levels of care process and how that resource ties into the conversation about discharge?
Ooh, great question. I won't go into too many specifics just because I know we have some non-PATH providers on the call as well. But I will give kind of a zoomed out version of the function of the higher level of care form and process at PATH, and what, how providers often use it through the lens of some of the things we talked about where like it's not a good fit and they clearly need more. So, as you know, in a private practice, and this is different than working in community mental health and other settings, you can't bill commercial insurance for care coordination activities. So I think back to my community mental health days, I spent hours on the phone back and forth doing referrals and coordinating with, third parties and the school and all this stuff. And I was billing for it. That's case management or care coordination. You can't through PATH and through commercial insurance. It's not reimbursable. So whenever a client needs more wraparound support, needs a higher level of care, it doesn't make sense for the PATH therapist to do all of that legwork. So PATH employs a care coordination team that essentially takes the baton from you and does that. So they work to find resources and referrals in the client's local area and get them connected to those. So in theory, it's really helpful. Like you fill out the higher level of care referral form, you pass the baton, you can keep working with the client in the interim, but it's a way to make sure that we're actively pursuing these wraparound supports that we don't provide in-house. We don't provide case management in-house. We're not doing groups right now in-house at PATH. We don't have an IOP. So when clients have these increased needs or wraparound needs, it really needs to go elsewhere. So zoomed out, that's kind of how it works. The care coordination team is also working with their insurance and their coverage. So I used to say one of the worst things we can do in this field is give a client a list of referrals for things that they can't access. And I've experienced this so many times in other treatment settings where it's like, well, we gave them a list of, X, Y, and Z, but it's like, but if those resources don't take their insurance or there's a 6-month wait list, help me understand how that was helpful. Or did we just kind of say to them, look what's out there that you can't access? So the care coordination team, again, does that legwork to really troubleshoot and connect them with necessary resources. The other thing I'll say is the term higher level of care in other settings, I always thought of higher level of care as like inpatient, right? Because inpatient's higher than outpatient. The difference is that PATH, the higher level of care form is not used for inpatient placement and it's not used for crisis evaluation, anything like that. Think of higher level of care through PATH specifically. That process is, I think of the services that are more intensive or more supportive than just outpatient telehealth. So IOP, group therapy. We have clients all the time that, present with disordered eating or specific conditions that really might necessitate targeted treatment outside of PATH. So not inpatient, not crisis, but anything that, med evaluation, psychiatry referrals are the most common. And again, that's to make sure the client is getting their needs met, but also recognizing like there's limitations to the scope of what we do. And you shouldn't be tasked with, doing all of that yourself. You should just be focusing on providing the service you provide.
Great, thanks, Anne. Another question. So if a client wants to continue with care, but doesn't qualify for kind of meeting the threshold of medical necessity, and that person wants to continue with private pay, how do you think about scenarios like that?
Yeah. So clients can self-pay even through PATH. If they wish to self-pay, they can do that. You still have to document in our EHR, and the medical necessity does look different. In fact, I think they're still required to have a diagnosis, but it doesn't have to be an F code. You can use V codes. So it does change the landscape. It changes the game a little bit when a client is self-pay. And yeah, I think the parameters around meeting medical necessity, especially for clients who, like sometimes I've had therapists say like, but what if them meeting with me is preventing symptom, decompensation or preventing symptom severity? In other words, like they're not meeting medical necessity right now, but they attribute that to the fact that like they have this very trusted, safe, supportive place to process. And that's really what's needed. So I think you could have a conversation with clients around self-pay. And if that's something that they're interested in, and you could continue care doing that outside of PATH, that might actually even look different. I can't speak to other settings or other organizations, but I do know it's an option through PATH. And yeah, it changes things a little bit.
Great, thank you. One other question kind of on the medical necessity topic. How often should you record a client's medical necessity in your session notes?
Great question. Try not to cringe when I say this, everybody, but I would do it every note. But I'm going to tell you how you can do it in literally 1 or 2 sentences. I think sometimes we get kind of worked up of how much do I document? What do I leave in? What do I leave out? And if you are a therapist in the PATH network, we have some resources, videos where I walk through like a sample note and talk through showing medical necessity in a note. But in the most basic terms, those things that I mentioned on that slide and that commercial payers are looking for are specific symptoms. So instead of just saying a client is depressed, client continues to have anxiety, just expanding a little bit to say like, client continues to experience the symptoms of anxiety, such as rapid heart rate, increased isolation, and so on. So just naming the specific symptoms that match the diagnosis. And then the functional impairment piece. This gets lost a lot. And so when we think of functional impairments, it could be, obviously in work and school and relationships. I think sometimes we think for someone to be functionally impaired, it means they can't do it. Like, well, my client goes to work, so there's really no occupational functional impairment. I would encourage you to kind of look at it a little more granular of like, just because they go to work doesn't mean they're functioning optimally. I have clients who they go to work, they have a job, but they're focused, like they can't focus, or they have to sit in their car for 20 minutes before they go in the morning just to try to work up the capacity to go engage and talk to people. Like that is occupational functional impairment. They're not functioning in an optimal way or the way that they want to be. So symptoms, diagnosis, functional impairment. And then the last piece is that clinical intervention piece. So instead of just saying therapist provided listening and support, you could say therapist provided listening and support and taught distress tolerance skill. Just adding that one little bit, like not everybody can teach a distress tolerance skill. Not everybody can, use some of the interventions you use. That's why you're a licensed therapist. So you could put their symptoms, how it's impacting their functioning, and the clinical interventions used all together in like a few sentences. It can be done pretty briefly. It's just a matter of kind of building that habit.
Great. Thanks so much, Anne. We have a couple questions around if a client is having a crisis. First question is any kind of resources you recommend in terms of like crisis centers or numbers?
Mm-hmm. Yeah, so 988 is always my go-to, and I'm sure that launched this past summer, I believe this past July, but the previous National Suicide and Crisis Lifeline that had a long number, I think it was like 873 talk or something, I don't even recall, used to be burned into my brain, but they switched it to 988, which I think is so much more readily accessible, easy to remember for us and for clients. They can text 24/7, they can call 24/7. I tell every client about 988. I remind clients about 988 all the time. And I document that I reminded them or we discussed, accessing 988 over the weekend if needed. So that's always kind of the default. Yeah, depending on their area. I mean, I'm in Colorado. We have local 24/7 crisis centers kind of sprinkled around the metro area that are intended to provide walk-in mental health support to avoid people just going to the ER. So maybe in their area, they have that. So yeah, I think there's a few different resources. One other thing that I'll share in regards to crisis management that I think gets overlooked. Many of us were trained to wait and create a safety plan when someone's in crisis, right? They disclose certain things and we say, okay, I think we need to safety plan. If you think about it, that's a terribly ineffective time to write a safety plan, right? Like someone's actively in crisis and we're asking them to identify coping skills and who they can outreach for support and a reason for living. I often liken it to like, it would be like if your house is actively on fire and that's when you're going to write an escape plan. Like, it's not the most ideal time. So this is not a requirement at PATH, but I do encourage providers to think about this. I write a safety plan with every single client, and I norm the heck out of it to explain that, like, we're all human, and sometimes life happens and sometimes things can escalate quickly. And it's just having this plan in place that, how do I know when I'm getting overwhelmed? How do I know when I'm not doing well? Who can I call when I'm not doing well? And so if you get in the practice of really having a safety plan across the board with your whole caseload, then if and when crisis emerges, that's just one more thing that you can direct them to, that you can use with them, that is protective for them, but it's also protective for you, right? That's documented in the chart. Like, we reviewed the safety plan. So just a little plug for safety planning.
Great. Thanks so much, Anne. And then the second crisis-related question, if there is a crisis, what are PATH's kind of procedures around that?
Yeah, great question. So it's interesting when you think about being a contracted therapist through PATH, right, or a therapist in the PATH network, you're still operating as an independent licensed therapist. So PATH doesn't have any prescriptive policies or procedures on how you handle crisis. The way you would handle it is the same way you would handle it in any practice. So, you're going to conduct a risk assessment when, if risk is present or, certain statements are made. You're going to safety plan if clinically appropriate, or reference the safety plan. And then you're either going to, potentially call 911 if it's an imminent risk or imminent crisis, or you're directing them to a crisis center. You might have to involve collateral. That's why, we can break confidentiality if it's due to an emerging crisis, a mental health crisis. That's why we have their crisis contact info in the chart. So I think, as anxiety provoking as that can be, of like, oh, what do I do? What do I do? Kind of going back to basics, especially in an outpatient telehealth world, there's only so much I can do, right? I'm not in community mental health anymore, where I could like physically walk the person over to our crisis center that's, across the street, or, different procedures that center had. So assessing risk, safety planning, and then involving, external crisis supports, or getting them to an emergency room or 911 if needed.
Great. Thank you so much, Anne. I think that, let's see. Okay, one more question on safety plans. So if you've done a safety plan with clients and you had a written copy of it, do you email or text a copy to them, or is it better to have them fill it out and then email it to them?
Great question. I think either's fine. I personally like to do safety plans collaboratively because, and this is just a quick clinical example, but sometimes clients will identify things on their safety plan that maybe are not going to be the most effective long-term. So for example, a client presents due to conflict with their partner, and it's a really complex, high conflict household. And then part of their safety plan of who you're going to call is your partner, like just by default. And so it's kind of, not prescribing for what them to put, but like, that's interesting. Like, let's think through that. What if the conflict is with your partner? What if that is what's driving these, suicidal ideation or this increase in symptoms? Do we need to put additional folks on there that are outside of your relationship that would be safe? Or I've, especially with younger patients, I've had them put things like, coping skills or things that you'll do. And they'll say things like, play tennis. And then you kind of talk to a parent or guardian. They're like, they've never played tennis. Like, I'm not sure why. And so I think collaboratively in session gives you an opportunity to really talk through how realistic, how accessible the plan is. That being said, any plan is better than no plan. If they want to use an app on their phone, there's a Stanley Brown app. If they want to do it in session, if they want to jot it down and email it to you. At PATH specifically, you're not required to have it in the chart. It's a good practice, but the most important thing is for them to have it, not us. So as long as they have a copy and you document that they have a plan, I think that's great.
Great. Thank you so much, Anne. Well, it looks like we're just about at the top of the hour. So that'll be all the questions we have time for. And yeah, thank you so much for everyone who joined. And thank you, Anne, for the wonderful presentation and walking through all those excellent questions.
Well, thanks, everybody.